Okay, well, it's 8:01 and we have 30 attendees. I expect these numbers to grow over the next few minutes. We should get started to give our speaker, and it's their first time speaking to us as a new faculty member. So very exciting. Want to make sure we give her all her time. So Angela Bazzi is an associate professor in UC San Diego's Herbert Wertheim School of Public Health. Her mixed methods research seeks to identify and intervene upon the social and structural drivers of infectious disease disparities. Her research has explored how HIV and other infectious diseases disproportionately affect people who use and inject drugs in the United States and globally. With KO1 and R1 funding from the from NIDA, she is currently leading and contributing to intervention and implementation research to improve access to HIV prevention, substance use treatment, and healthcare services for people who inject drugs. She's an editorial fellow at Drug and Alcohol Dependence and at top public health courses on substance use and intervention development. Dr. Bazzi completed an MPH at the Johns Hopkins School of Public Health, PhD in Global Health at UC San Diego, and a postdoctoral fellowship in infectious diseases epidemiology at the Harvard School of Public Health and Fenway Health. Prior to her research training, she worked in reproductive health programming in the United States, or at the United States Agency for International Development. We are so pleased to have you here. I'm really excited that you can share your work with us. Just for you and for everyone else, questions or comments can go into the chat. If you'd like to message me privately, I can share it privately later. And Dr. Bazzi, I will try to give you a 15-minute heads up so that we can save some time for discussion. And with that, to you.
That's great. Thank you so much. I'm really excited to be here. I think it's a tough act to follow Joel Wertheim from last week. I don't have any great pop culture references or videos, but I'll do my best to keep this interesting. So as getting started, I don't have any disclosures, any conflicts to disclose. I do have funding from NIDA and from a couple of centers for AIDS research, including now the San Diego Center for AIDS Research. And I'd just like to briefly acknowledge my team of collaborators, mentors, mentees, as well as the agencies that have supported our work and the study participants that have really made all of this possible. So as an overview, I'll give some background on the current epidemiology of HIV in people who inject drugs in the United States. And I'd like to use Massachusetts as a case study. There was a large HIV outbreak in Massachusetts a couple of years ago, and we learned a lot from the investigation of that outbreak, as well as some ongoing research that's happening. And then I'll talk briefly about some of our own research findings and how that has led to a PrEP intervention trial for people who inject drugs. And I'll end by talking about some of my ongoing research in implementation, as well as new PrEP modalities. And I hope that this can lead to some follow-up conversations with many of you. So as background, for the first time in several decades, HIV incidence is no longer declining among people who inject drugs in the United States. And on top of the approximately 1 in 10 new HIV diagnoses that are identified in this population, we've seen several notable large outbreaks in diverse regions of the country, including urban, rural, and suburban areas, and also including cities where there have been longstanding syringe service programs, such as Seattle and Philadelphia. And this is happening in the context of increasing injection and sexual exposures to HIV in this population. And so, as many of you probably know, there is currently widespread contamination of drug markets with fentanyl, which is a potent synthetic opioid that has a much faster onset and shorter duration of action than heroin. So this leads to higher injection frequency. And in a lot of the work I've done in the Northeast, it isn't uncommon for people to tell us that they inject 8, 10, or even 12 times a day. And so this requires a very high volume of sterile syringes and other drug and preparation equipment. It also requires a lot of individual agency and control over their circumstances, which is really difficult to ensure for this population. So fentanyl related to these factors has been associated with increased receptive syringe sharing, as well as the sharing of drug preparation equipment. And this is manifested in increasing incidence of a number of infectious diseases, including hepatitis C, infective endocarditis, skin and soft tissue infections, as well as bone and joint and other infections. It's also important to note that there are rising levels of polysubstance use among people who inject drugs in the United States, including psychostimulants such as methamphetamine. And historically, in the context of the opioid epidemic, this was a little bit under-recognized, but there's a lot of increasing attention to it. And as we know from decades of HIV prevention research, these psychostimulants have been associated with increased sexual exposure to HIV. Another manifestation of the increase in fentanyl in illicit drug supplies has been a rapid increase in overdose deaths. So I'm sure many of you are familiar with this image depicting the distinct waves of the opioid overdose epidemic, beginning with prescription opioid overdose, which was then sort of overtaken by heroin around 2010 due to a number of policy changes. And then in 2013 and 2014, there was a real inflection point when illicitly manufactured fentanyl started to really overtake the heroin supply. And so we now believe we're in what we're calling the fourth wave, which involves these psychostimulants that are also potentially contaminated with fentanyl or being used in combination with fentanyl intentionally. And that's leading to increases in overdose deaths due to those drugs as well. This graphic depicts that a little bit more clearly. And so we can see in this brown line representing fentanyl that there was an increase that's really kind of driving the overall increase in opioid-related overdose deaths. But it also shows how during the same period of time, there were smaller increases, but increases nevertheless in the use, in the identification of cocaine and methamphetamine in overdose deaths attributed to opioids. So I think that's important context for thinking about HIV transmission and what's happening in this population nationally. This depicts the kind of steady decline I mentioned in HIV transmission among people who inject drugs in the United States, which started leveling off around 2013, 2014. But this is national data. And so we know that this obscures important subpopulation differences. And fentanyl is believed to have entered, really kind of taken hold of drug supplies in the US Northeast. And so kind of I'm switching back and forth between fentanyl and HIV, but I think it's important to note that there is geographic variation in drug supplies. And the overdose deaths that were attributed to fentanyl were really identified earliest and kind of most profoundly impacted the Northeast in the early years following that inflection point. So if we look at Massachusetts, which I'd like to present as a little bit of a case study, we can see that starting around 2014, there was actually an increase in new HIV diagnoses among people who inject drugs. And so this kind of aligns with some of the data on increases in fentanyl in the drug supply. And in 2017, the State Department of Public Health issued an advisory to clinicians, warning them about transmission, increasing transmission due to injection drug use. And this advisory specifically mentioned fentanyl as well as psychostimulants. This actually resulted in a large CDC investigation of the outbreak, an EPI-8 investigation that was conducted in collaboration with the State Department of Public Health. And they used a number of different investigation methods, including molecular surveillance, chart review, quantitative surveys, qualitative interviews, and ethnographic fieldwork. And over this roughly 3-year period, they identified 155 cases of linked cases of HIV in people who inject drugs in two communities, Lawrence and Lowell, Massachusetts, which are in the northeast part of the state and are believed to be the sort of historic entry points for heroin and then later for fentanyl into drug markets in the greater Boston area, and then further south in the Northeast and even into the Mid-Atlantic region. So the investigation findings are really informative. Based on all of this data, the investigators attributed the outbreak to this early introduction of fentanyl, as well as the increasing prevalence of stimulants. There was a high prevalence of cocaine use in one community and methamphetamine in the other. And there was a high prevalence of sexual risk behaviors that we know increase HIV transmission. The report also described homelessness and incarceration as factors that significantly interrupted care for this population, as well as access to prevention services. There was also limited HIV testing, and relatedly, there was very low viral suppression among people in this population who were living with HIV. Just a couple weeks ago, there was a more in-depth description of the qualitative data published in the International Journal of Drug Policy that also cited an additional factor that I think is complicated, but something we probably should think about. And they also, they had some evidence that overdose prevention messaging that has encouraged people to not use and inject drugs alone may have had an unintended consequence in encouraging people to use drugs together. And just based on what we know about the high injection frequency and limited access to prevention services, sharing injection equipment and syringes in these contexts was almost inevitable. So it's not to say that we shouldn't use this type of messaging, but it is important to understand the context and kind of how it's playing out in the real world. So since that outbreak investigation, the state of Massachusetts actually declared a statewide outbreak of HIV among people who use drugs. There were clusters of HIV identified in Worcester, Boston, and a couple of other cities beginning around 2017 and continuing through until the present. And in Boston, where my colleagues and I had done some research, there was an increasing number of cases identified in several specific neighborhoods. And we know that there were actually over 100 cases identified in less than a 2-year period. We think that this was actually exacerbated by COVID, when access to prevention supplies and HIV testing dramatically decreased in this population. But some of the factors that we know are involved are very similar to the factors that I just described from the outbreak investigation in Lawrence and Lowell. So I'd like to step back and talk briefly about the tools we have available for HIV prevention for people who inject drugs. So first, and very importantly, are medications for opioid use disorder, which we know are very effective in treating opioid use disorder. They reduce the use of opioids, they reduce injection frequency. We have strong evidence that they reduce HIV acquisition, as well as overdose, morbidity and mortality. And they also improve a number of other health and social metrics. Next, we also have syringe service programs, which are increasingly available, although there's pretty wide geographic variation in their accessibility. But syringe service programs are supported by decades of robust evidence. They reduce injection-related risks for infectious diseases, and they can also provide a lot of additional services, including condoms, sexual harm reduction counseling, HIV testing, naloxone education and distribution, and referrals to drug treatment. And then there are complementary models such as pharmacies for accessing syringes, and kind of newer in the United States, although not in other countries, are safe consumption and safe injection sites. Rhode Island just actually recently passed legislation that will allow a pilot program of safe consumption sites. And Massachusetts is kind of following in those footsteps, and there's legislation that will be presented in about a week and a half to implement an even more robust pilot program with long-term follow-up. But there are some challenges with these existing methods. And when we think about the current context that I presented, so there's a less clear impact on sexual risk reduction from these HIV prevention tools. And we know that they've been complicated by fentanyl and polysubstance use, including stimulant use in this population. And as I mentioned, access to these services is often limited, and there's pretty wide variation geographically in terms of where and how services can be accessed. We also have evidence that there are important racial and ethnic disparities in terms of who is able to access services. So my research has focused on improving uptake of PrEP in people who inject drugs in the United States. As a little bit of background on PrEP, as I'm sure many of you are aware, PrEP is currently available in the US as a daily oral antiretroviral medication, which was found to be efficacious in the Bangkok-Tenofovir study, which was the only clinical trial that actually really focused on people who inject drugs. Several of the other trials explicitly excluded people who reported injection drug use or other drug use. So this is really some of the only clinical trial data that we have. But from this trial, we saw that the effect size is roughly in between effect sizes identified from other studies. There was a slightly wider confidence interval, but we know from some post hoc analyses that just like the other trials, adherence strongly influenced efficacy. So based on this evidence, the US CDC, the World Health Organization, and the US Prevention Services Task Force has recommended PrEP for HIV prevention in people who inject drugs. Unfortunately, most research and actual uptake has been observed in other populations. And as I mentioned, people who inject drugs have been excluded from a lot of HIV prevention drug trials. And we can see from just looking very quickly at the literature that's available, they've really been underrepresented in a lot of clinical and community studies following FDA approval of PrEP in 2012. So this entire PrEP care continuum, which involves steps from awareness through uptake, adherence, and persistence in care, remains really understudied. So there are probably a lot of reasons for this. And I think we have to consider very carefully the potential of stigma and biases against this population that have manifested in the existing research. But people who inject drugs have long been considered a hard to reach population in health sciences and social sciences research. And this is related to the fact that we don't have a registry, there's no sampling frame, and the population size and boundaries are often unknown. There are also significant social and structural barriers for this population to engage in research. So first, I believe that addiction-related stigma has really influenced the research agenda in this area, which is something I'd be happy to talk about later. But we know we have data showing that people who have experienced health stigma in healthcare settings and health sciences research tend to avoid clinical settings and express distrust of researchers. So there are very clear consequences of this addiction-related stigma. The criminalization of drug use and sexual behaviors that are common in this population, such as sex work, have also further led to privacy concerns in the population, with many individuals not wanting to be found by researchers or not wanting to provide data on some of those specific behaviors. And finally, there are structural factors such as poverty, homelessness, and limited phone and internet access that prevent access to research studies. And this has become a big problem during COVID too, when a lot of research has switched to virtual. So my team has been working on engaging people who inject drugs in PrEP-related research since 2016. To date, most of my research has been in the US Northeast, although with funding from the San Diego CFAR, I'm now working on extending some of that to San Diego County, which I'll talk about near the end of this talk. But around 2016, we started doing some research in the capital cities of Massachusetts and Rhode Island. And we quickly realized with the outbreak being declared that we needed to expand that work to include smaller cities, suburban areas, and less urban or rural areas in both states. And so we used surveillance data on hepatitis C, other infections, and overdose to identify what we called kind of informally as hotspots for potential HIV transmission in these communities. So our research has been qualitative, primarily qualitative to date. And we've partnered really closely with syringe service programs to recruit this population. And we typically visit sites in person. This was challenging during COVID when we adapted some of these methods to be semi-virtual. But we really have relied heavily on our syringe exchange partners in helping to make this research feasible. And so over this period, we've conducted qualitative interviews on HIV susceptibility and interest, acceptability, and intervention needs related to PrEP with 125 people who inject drugs and 63 professional key informants from health and other sectors who have professional experience working with this population. So I'll give a brief overview of some of our findings and how that led to some of our current intervention research. So first, we've found that PrEP knowledge is suboptimal in this population. Few people have accurate knowledge of PrEP and don't know how to access it or really how it works. And there's some confusion with other medications, including medications for opioid use disorder, as well as post-exposure prophylaxis. And so here's a quote from a woman in Boston who told us, I know about the one that if you're exposed, you go to an ER within 72 hours. I don't think I've heard about the one you can take before. So that's a very common response that we get when we ask people, before this study, have you heard of PrEP and what have you heard? And so we usually don't get very specific answers to that question. And our key informants have attributed that to marketing that has really focused on other populations, including men who have sex with men, as well as healthcare providers' lack of time when interacting with this population. And there are some studies that have also demonstrated lower willingness of healthcare providers and PrEP prescribers to talk about PrEP with this population compared to other populations. We also identified in our work relatively low HIV risk perceptions, despite some of the risk behaviors that people were reporting during the same interviews. And so related to this low HIV risk perception, PrEP interest has been pretty low, sometimes kind of mixed, but we've sort of identified PrEP knowledge, HIV knowledge, and risk perceptions as a potential intervention target. We've also identified multi-level barriers to taking up PrEP, as well as to adherence. And so we've kind of organized this in a multi-level way. And as I mentioned, at the individual level, we've found low PrEP knowledge and risk perceptions. We've also heard some concerns about PrEP side effects, although that hasn't been as prominent in interviews as some of these other factors, including competing health priorities related to addiction and homelessness. So as a man told us, the drugs come first. If you're out there hustling, your appointment happens to be coming up, you're not going to go to it. So that's a very common type of reason for difficulty accessing prevention services. We also identified some interpersonal barriers, mostly relating to negative experiences in healthcare settings in the past, which I'll talk about in a moment. And then clinical, social, and structural barriers, including the fact that PrEP services aren't always very accessible for this population, depending on where they're located. The PrEP screening process, which has become easier, and there are a lot of innovative models to making it easier, making PrEP available on the same day that someone's seen. But that was also described as a potential barrier by our study participants. And then, as I've mentioned, some of the structural factors like homelessness, incarceration, transportation problems, and poverty in general that really limit access to health and prevention services more broadly. One of the strongest emergent findings from our research over the years has been the role that stigma plays in deterring people from accessing healthcare. So this is something that came up in one of our earliest studies starting in 2016. It's not something we have at that time were asking about directly. It just tended to emerge on its own when we would ask about health concerns and access to healthcare for those health concerns. And so we've found that most of the people we've talked to in our research describe anticipating stigma because in their experience, it has been common and routine. And it carries a significant impact. And it doesn't always matter if the stigma that they're talking about was experienced yesterday or 25 years ago. It's a very powerful force in their decision-making to access or to avoid healthcare. So there have been a number of studies that have described stigma. One of my mentees at the time who had been conducting interviews was really kind of impacted by this finding and really interested in it and did a very careful analysis that was sort of descriptive relating to people's experiences of stigma. And around the same time, our colleagues in California, including doctors Jennifer Syvertson and Robin Polini, published a paper that was essentially the same as what we were trying to write up. So we went back to the data and kind of dug deeper and identified specific reactions that people have to stigma. And these include delaying seeking healthcare, withholding information from providers, and particularly downplaying pain, and then seeking care elsewhere in community-based organizations and syringe service programs. And so this is a quote that's, I think, very typical of some of our interviews around this topic. So the minute they find out you use drugs, they don't want to help you at all. They change their whole attitude. It's how they look at you. And it makes me standoffish. It makes me want to lie. It's tough being someone who uses drugs and getting medical care. Right away, they think you're looking for something. I'm like, buddy, I can get it on the street. I'm here for this other issue, you know. So based on these qualitative findings, we wanted to start developing an intervention. We also felt that we would probably need some preliminary data that was a little bit more generalizable, as qualitative research is frequently criticized for not being generalizable, even though that's not really the intention. So we wanted to use some quantitative data, and we had access through our collaborators at the State Department of Public Health to the Boston data from the National HIV Behavioral Surveillance System, the NHBS, which is a survey conducted in specific at-risk populations in the United States. It rotates between those populations every year. And so the PWID data is available every 3 years. And they use respondent-driven sampling to recruit participants who are eligible if they've injected drugs in the past year, which I think is important because we've seen data emerging actually from the West Coast that people frequently switch back and forth now out of fear of fentanyl from injecting to smoking, and that kind of happens in a cyclical way sometimes. So these were individuals who were living in the Boston, the greater Boston area. It actually included a zip code in Lawrence. So it's pretty relevant to kind of where the initial outbreak occurred in people who inject drugs, as well as Boston, where there's an outbreak that's ongoing. So we wanted to know, based on the US Prevention Services Task Force recommendations, how many people in this population might actually benefit from PrEP. So we worked on translating these recommendations as well as some of the clinical guidelines into our NHBS data, which is a very detailed battery of behavior questions relating to drug use as well as sexual risk behaviors. So it wasn't too straightforward to do that. And I definitely don't envy those of you who prescribe PrEP. I think it can be complicated and tricky to ask people about these behaviors, especially sexual risk behaviors in the population of people who inject drugs. But nevertheless, we were able to do our best to do that. And we found a very high prevalence of PrEP indication in this close to representative sample of people who inject drugs, with 92% reporting risk behaviors that carried some indication for that they could benefit from PrEP. And so within that 92%, the majority were indicated for PrEP based on injection behaviors alone. But there was also a kind of substantial portion that reported both injection and sexual risk behaviors. And we know that these things overlap, and it can be in kind of complicated ways. So as someone told us in our qualitative work, I'm careful. I've been really careful with my drug use, but I've done riskier stuff. Like the other day I shared needles. My needle broke, the syringe exchange was closed, and I didn't have money and I felt sick. I try to clean my syringes as much as possible, but I've been sharing cookers, which is something I didn't used to do. Oh, and I've also been doing sex work. So it would sometimes come up in these longer narratives. And I think the NHBS data is pretty powerful in that it can at least capture these overlapping risk behaviors.
Angela, can I just ask you a quick question about that?
Sure.
So the PrEP indication, was it based on the CDC guidance for PrEP indication or something else that you use? Because that's very high. And I'm not, well, I guess if they're injecting drugs, that would be the potential reason that I was just curious what you used for the PrEP
Yeah, so it was,
indication.
great question, Jill. Thanks. It was based on the CDC guidelines. And it was the way we kind of operationalized that using the NHBS data was pretty broad, because there were so many risk behavior questions included in NHBS. But I think one thing that is interesting about this is that the NHBS data does not do a great job of capturing injection frequency. It maxes out at daily or more injection. And that wound up being kind of the majority of this sample. And even though that's not an indication for PrEP in itself, I think related to that, the prevalence of receptive syringe sharing was really high. So that was kind of the primary driving factor that you see in this 69%.
Yeah, and as I asked, I realized it's somewhat loose if your sample is people who inject drugs. The question or the two questions I believe in the CDC guidelines are engage in injection drug use in the last 6 months, or is it share needles or syringes in the last 6 months, and then have been, I'm sorry now, and I should know this, and have been in drug rehab or recently discharged from a drug rehab facility. I'm forgetting what the two of them are, but I feel like they're pretty broad.
That's great. There is a broad, a sort of broad language about having been in drug treatment that I believe was actually revised out in a more recent iteration of the clinical guidelines, but I might be mistaken. But regardless, that is not measured very well in NHBS. So what we really had to focus on was the risk behaviors that people reported, either related to injection specific behaviors or sexual risk behaviors. And the NHBS is, it's a little bit complicated in how it asks about sexual risk behaviors. It sort of, it has different modules within it. And there's a very detailed section about specific sex partners, such as like a main partner or, not a main partner. So we were inclusive and we kind of looked at people's responses to all of those questions, which could be contributing to this high prevalence. But you're right, your point is well taken that the guidelines are very broad. And of course, considerations about actually prescribing PrEP to an individual really need to take into account, that person's specific situation. So based on all of these data, we developed and received funding from NIDA to test the PrEP for Health intervention trial. And our approach to this was kind of to throw everything we could think of at the problem. And we wanted to locate the intervention in a non-stigmatizing kind of trusted setting that this population could routinely access. So we've developed a behavioral intervention that involves motivational interviewing, education on HIV and PrEP, as well as some problem-solving therapy, and then ongoing PrEP navigation support over a period of 3 months by a navigator who is a lay person trained in the intervention, who is based within the syringe exchange program, and can help people access PrEP services, whether they're provided in or near SSPs or sort of outside to other providers who they might be referred to. So we've just gotten this started because of COVID. We experienced some delays. We really wanted it to be in person. And syringe exchanges across the country have been really impacted by COVID in the sense that they were very quickly identified as essential services and tasked with providing a lot of COVID-related services. And so the agencies that we had partnered with were feeling pretty stretched during the pandemic. And it was only really this summer that we were able to kind of get things going. But so the primary outcomes that we're targeting in this intervention are PrEP uptake and adherence among people who inject drugs. And then we're looking at PrEP persistence over time as a more of a secondary outcome. And so that will involve reviewing pharmacy records as well as appointment records to see if people have been retained in care. We're also working on some implementation research with Boston Healthcare for the Homeless that has developed an innovative low threshold PrEP program for people who inject drugs and are experiencing homelessness in the greater Boston area. So this is a mixed method study, and we've completed some of our quantitative analyses so far. And we've found that among people who inject drugs in this population of patients of Healthcare for the Homeless, 239 individuals were linked to their PrEP services in a roughly 2-year period. And we found that rates of PrEP initiation following this linkage to the PrEP team, as well as rates of persistence, were comparable to those that we've observed in other populations that arguably may have some social and structural advantages in terms of accessing care. The cumulative probability of staying on PrEP for 6 months in this population was 44%. And so that might not sound high, but this is probably one of the most robust PrEP programs that exists nationally, specifically for this population. And it was really developed in direct response to the increasing HIV transmission that's been observed locally. So following this quantitative work, we wanted to know what are the key elements of this program that are actually helping it to succeed. And if there are any areas for improvement, maybe we could learn about that by actually talking to patients and providers. So we conducted qualitative interviews with those 2 groups from March through the end of the year of 2020. It was all semi-virtual, where members of the PrEP team at Healthcare for the Homeless were able to kind of provide an introduction to the study and then refer individuals to our study team who were available by video conference. So this was not completely smooth. We worked out a lot of kinks during this process, and the data collection wasn't perfect, but we were able to get it done. And we definitely learned a lot about the program through these interviews. So there were 21 patients who were recruited into our study for this qualitative component. They were pretty demographically diverse. They were largely street-based. Their complete lack of housing and shelter, basically. And there was a high prevalence of injection frequency and polysubstance use that is somewhat characteristic of this particular neighborhood in Boston. So you can see from, this is just some statistics on our qualitative sample, and we were missing data from one individual, but everyone was using heroin, but almost everyone was also using a stimulant. And then there were a lot of other drugs that were commonly used as well. And then injection frequency was pretty high. And this is kind of what we're seeing around the state in our work as well, with about half of the sample reporting injecting at least 7 times a day. So some of the key elements of the program that we've found through these interviews that have included providers as well, that we think are really helping to make the program work are their provision of tailored marketing materials. So they actually had a member of their patient population help develop. He was a graffiti artist, and he helped develop some PrEP educational materials that have been distributed throughout shelters in the city. A lot of participants also talked about appreciating hearing about PrEP from people who they trusted, who included other people who injected drugs and had used PrEP, as well as some of the providers on the PrEP team, including the street medicine team. Another key feature of the program was same-day PrEP prescriptions and the use of an on-site pharmacy. And so there was a lot of collaboration with other services offered by Healthcare for the Homeless. They have a wound care clinic that's conducted in collaboration with the local syringe exchange. And they also relied heavily on collaboration with providers in their infectious disease services, as well as their office-based addiction treatment service. And they've had a very tailored approach to prescribing PrEP, where they leverage their on-site pharmacy, which is willing to repackage PrEP into 7 or 14-day blister packs so that patients don't feel concerned. I have a couple of quotes that show this. They don't feel concerned about losing a 30-day prescription, given the high levels of theft that occur in this population. And they also have on-site medication storage available. So as a couple of people told us about the short-term PrEP prescriptions, if they lose it, if their backpack gets stolen, their things get stolen, they feel a little bit more confident that they can, go back to the program and get the rest of their prescription. And I think that confidence is actually very helpful in motivating people to take PrEP. It's related to self-efficacy and the idea that, something that a new behavior is actually possible. The program more recently, so towards the end of 2020, implemented much more intensive street outreach as well, involving daily dosing and delivery of PrEP by the PrEP services team. There have been a couple of different engagement centers set up by the city, which are basically big tents that are open air. They've provided bathrooms, hand washing stations, now harm reduction supplies. They're definitely being threatened. There was recently a threatened sweep of one of the largest areas where these engagement kind of activities have occurred, just because of the high prevalence of public drug use that occurs in them. And so it has really actually raised prominence of the debate around safe consumption sites in the city. And it's actually given us a lot of hope that this legislation might actually be taken seriously this time around, because it's clear that a longer term solution is needed, and that people really need a place to go. But so this daily dosing was delivered in the engagement center, but also through a number of shelters in the immediate area, and just street-based outreach, walking the streets. And then something that emerged really strongly from the patient interviews was the importance of trust and respect within the PrEP program. So as someone told us, since I started PrEP, I take it, and when I lose it, I call the navigator. And it goes way beyond just the medication, it's the people involved. They're like angels. And I think that's why I'm still taking PrEP. They're personable and comfortable to be around. People can be stuck up and look down on you, but they've never done that once. A lot of people come in being really nice, and then they start getting bitter. But the PrEP program staff have never changed who they were, not once. And in the years that I've known them, not once have they changed. And this place can make you bitter real quick. and the dedication. They're doing a job, yes. They get a paycheck, yes, but it's way beyond that. They're doing this with such altruicity, meaning they do things that are above and beyond, and they don't expect anything in return. And so this was a woman who had been on PrEP somewhat on and off, but for a 2-year period had been engaged with the program. So I'm trying to extend some of this work to the West Coast, where we know that fentanyl is fentanyl is here. Methamphetamine's probably never left, but fentanyl has definitely emerged here, and so we're doing research with support from the San Diego CFAR on new PrEP modalities, and specifically on the acceptability and feasibility of delivering some of these newer, longer acting forms of PrEP to this population. So we're doing some qualitative research to try to understand what people actually think about some of these products. We've done several interviews so far, and we've learned quite a bit already, which we'll continue following up on. We are working, we're fortunate to work with Dr. Strathy's La Frontera cohort study, and we plan to soon implement a survey using a discrete choice experiment to understand PrEP preferences in a larger sample of people who inject drugs in San Diego County. And we also hope to evaluate the feasibility of the preferred PrEP modalities and programmatic strategies through key informant interviews, which will happen in a subsequent phase of this project. And so I'd like to conclude just by stating that, with the current drug market trends that we're observing, I believe we need more intervention and implementation research to better get PrEP to this population, and also to get other advances in infectious disease prevention and treatment to this population, which has unfortunately been excluded from a lot of biomedical research to date. We've written a commentary about HIV prevention drug trials specifically, but people who inject drugs are explicitly excluded from a lot of other trials, including the POET trial, other trials that from which they could definitely stand to benefit. So I think I'm looking forward to having some discussion with you, and thank you so much for your time and attention.
Thank you. I was just about to give you the warning, but you timed it perfectly. So there was a little discussion, and one of the people who also got her PhD and in the joint doctoral program had to hop off. She said I could share her comment because we were chatting separately. But I was wondering if Dr. Aldous, Nettie, are you still on and there she is.
Yeah, I'm not sure if it was the same discussion that Nicole was bringing up, but I was just thinking about from a West Coast perspective, obviously people who inject drugs are an important population, and need sort of extra focus because they're often excluded from this research. But then many of us especially on the West Coast, are dealing more with people who don't specifically inject, but still have these same risk factors and the same issues. And so I feel like sometimes by putting that hard line of people who inject drugs, we forget that this is so generalizable to people who use drugs, especially when you see that a lot of the risk is not even necessarily the injection itself, but the activities around the injection or the commercial sex work or sexual activity in general, et cetera. So I was just more commenting about that. I sort of feel like sometimes as a West Coast mostly doctor, I'm left with this gap of my patients who don't inject, but nonetheless really belong in this research or should have access to these kind of prevention services or this kind of either research or outreach opportunities.
Yeah, I completely agree. And thank you for bringing that up. And in some of our new work we're proposing, we hope to focus on kind of more broadly just people who use drugs. We've got some great evidence from the West Coast. It's published recently showing that there oftentimes people transition from injecting to smoking or using drugs in other ways because of knowledge of fentanyl and concern about overdose. So we know that things, can evolve, and there's great geographic variation in local behaviors and practices. I think it is important that, as you mentioned, a lot of the biomedical research has excluded not just people who inject drugs, but people whose substance use, like some, to quote some of the exclusion criteria of these trials, it's people whose drug use, at the discretion of the study investigators will interfere with their ability to comply with study procedures. And so that kind of language, when there's not, exclusion criteria based on actual science, but it starts to make it sound like, some of the potential biases that, that I think we believe are apparent in research. So I very much appreciate your point and agree that we really do need to think more broadly about how we're conceptualizing substance use and what that means for who's getting included or excluded from this research.
I will just make the comment, and I agree with inclusion for as many groups as possible in this. I would say that for people who don't explicitly inject drugs, the other behaviors that we're referring to probably was almost definitely is entwined in sexual risk. Maybe not always, but it would seem like those individuals would be captured in other ways, in other opportunities. And Nicole made this comment, she did, so Nicole Pepper was who I was talking about and was commenting a little bit that, she did some qualitative research with poppers, and that people don't necessarily think of poppers as a drug of abuse, but it's a tool for sex, again, connected to sex. And to me, sex is where it comes down to a lot. If you're having sex, you're eligible for PrEP. Like, it's as simple as that. But we don't always screen for it. So the idea is maybe in these screening tools, which aren't the be all end all, but I think a lot of providers use it that way because screening tools help and make life easier. So if it actually was there, that might help someone. But to me, the point is most of those say, are you engaging in sex? And if you are, that's it. You get PrEP. So that's where, to me, where the injection drug use comes in a little bit separately, because they may not be having sex, and therefore that PrEP indication may not exist. And that's sort of how I think of it. I think it's all sort of.
The thing that catches my eye, though, about this research, which I thought was so well presented today, thank you, was that, people, as you get to talk to them, especially with that qualitative, where you start to see that actually, I'm real careful with my needles, but then there was sexual activity, or, so they're in the study because of injection drug use, but actually what you're finding is that some of the risk is around things around the drug use. And so for people who say, well, I technically didn't inject, so I didn't enroll in the study, and no, they say no to the sex use, but sex behavior. But then as you get to see, you find that this population has all these secondary risks that they don't really check off the box, but you get to find out as you work with them. So I think most of us think of methamphetamine use of any form as being an HIV risk factor, even though the person might say that they might feel like they don't have other risk. And then we would still want to use the type of research you're talking about to engage that population, because I think it's relevant and applicable.
Right. And I agree with what you said about kind of building a relationship and getting to know someone over time. And we've found in our qualitative work that people will not endorse specific sexual behaviors early on, but then throughout the course of the interview, they start to disclose more. And like a good example of that is with some of our male participants who don't identify as gay, but have engaged in transactional sex. And so that is something that I think is difficult to screen for quickly when you don't know someone.
And I'd say outside of, this bubble of ours, where this is what we do a lot of the time, if you're in a primary care, office or something like that, a gynecology clinic, you may not be doing that to the same degree that we are. And we even find it hard, and it is part of relationship building, and it may not happen at the first visit. It may happen in the future when they feel like they actually, feel comfortable sharing or disclosing. Does anyone else want to make a comment? Lots of people on this call listening in who are engaged in work in this arena. So I'm hoping someone will. There we go.
Angela, nice talk. Sorry, I only got to see half of it. I had another conflicting meeting for the first half. I think the relationship between methamphetamine and fentanyl in San Diego is complicated. And this is more of a comment than a question. And I think it's unclear how many people know that they're using both in co-use, or whether people are getting fentanyl in their methamphetamine. But one thing that is certainly clear is that the number of fentanyl overdose deaths is skyrocketing in San Diego. So, and you see in about half of those deaths, you see methamphetamine as well. So I just think the co-use, or the unknown co-use, is a really important aspect here, and something that all of us collectively need to understand better if we're really going to be able to do effective interventions. Because I think they have, there may be different interventions that work for whether people know they're using fentanyl or not. People know what they're getting and where they're getting it. So it's more of a comment, and just that there's a complicated relationship, but certainly fentanyl is increasing in San Diego. Certainly overdose deaths that have fentanyl on board are increasing, but most of those are also in the context of methamphetamine. So just a comment.
That's a great point. I really appreciate that. And I think, polysubstance use tends to be really complicated and complex. And, it's not always that people are injecting multiple substances, they may be, or not, using them with the same regularity or frequency. So some of the people we've talked to so far, which is just a very small group of people, and I'm sure you all have much better knowledge of this than I do, but people have described various patterns of polysubstance use involving methamphetamine, ranging from kind of co-injection of both substances to, maybe just occasionally smoking or methamphetamine sometimes, like not as regularly as they're injecting fentanyl. And I think, you're right that people don't always know what they're getting. And so that's what is, potentially helpful about drug checking services, or, if we can actually get information on drug supply and contamination of drug supply back to the community. I think, those could be some really helpful strategies for overdose prevention. But thank you.
Agreed. Great work.
Hey, Angela, it's Laura Bamford. Thank you for an amazing talk. I found your point very interesting, that as the message has been never use alone, that may have an unintended consequence of people using together and maybe increasing HIV transmission. And in Philadelphia, where I came from about a year ago, usually among people living on the street. And so not only this message of not using alone, but people living in tents and homeless together on the street. And really, I think almost everybody who was newly diagnosed was also homeless. And I think that's, again, and here in San Diego, having the 4th largest homeless population in the country, I think that also puts our population at enormous risk of HIV acquisition.
Thanks for that point. And I agree that the finding from, this is from the outbreak investigation, and it was just published recently. And I did find it really interesting that that was kind of a point that was raised. I think it did emerge a little bit in the qualitative data, but that doesn't mean, like, I think sort of what you're suggesting, it doesn't mean that the overdose prevention messaging is causing people to use or share and, together, and that there are very likely these structural factors that are encouraging that, and just the environments that people are in when they're using that make sharing virtually impossible. And I think what we tend to hear from people is that they're aware that HIV can be transmitted through syringes. There isn't as much awareness or concern about HIV being transmitted through other drug preparation equipment. And those supplies aren't always accessed as frequently. And so people tend to share those even more. And we don't know at least from the Massachusetts outbreak, kind of what it was that was promoting transmission exactly, but we've heard, kind of anecdotally and from a lot of the providers we work with that, and when we have evidence just from, the increasing prevalence of skin and soft tissue and other infections, we know that people are definitely sharing cookers, other things that they use to prepare drugs, which is of concern for numerous infections. Yeah.
Well, it's 9 o'clock. I think that was a great way to end. And I think it's a great thought-provoking talk, great discussion. And Angela, we're very happy to have you back, doing some excellent work. And hopefully this will lead to some future collaborations with people who are listening. But thank you so much. Really appreciate it.
Thank you. Thanks, everybody. Thanks for your comments. It's great to meet everybody.
And everyone, next week, we're going to take a hard right turn and go to some COVID therapeutics because it was requested by people to know sort of what's happening in the outpatient and inpatient world. So we'll have a couple of ID doctors, not really in the HIV world, coming to speak with us. So just FYI. Have a great Friday and weekend. And again, thank you so much, Dr. Bazzi.